My personal preference is brigatinib because it has the longest reported PFS, currently stated as 15.6 months post-crizotinib. Brigatinib covers majority of the resistant mutations, so you don't have to biopsy the patient, although other options could be appropriate, such as alectinib and ceritinib. The trial that led to brigatinib approval is called ALTA trial. ALTA trial took patients who have failed crizotinib and randomly assigned those patients into two arms. Arm A received brigatinib at 90 milligrams. Arm B received brigatinib at 90 milligrams for 7 days, followed by dose escalation to 180 milligrams. The trial was not designed to statistically compare those two arms. The purpose of having two arms was to choose the winner, to choose the arm that has the best efficacy and to move it for an approval. Patients who were enrolled into ALTA study had a performance status of 0 to 2. Prior chemotherapy was allowed, but prior second-generation ALK inhibitors were prohibited. The median follow-up of the study was 9 months. In ALTA study, 180 milligram arm was a winner in pretty much every category. It showed a higher response compared to the 90 milligrams arm. It showed a higher progression-free survival of 15.6 months compared to about 9 months of 90 milligram arm. It showed higher CNS response and higher intracranial progression-free survival. Toxicity was slightly higher in 180 milligram arm, but toxicities were manageable and dose discontinuations were infrequent. In ALTA study, nausea and diarrhea were reported in approximately 30% of patients, and this is all grades nausea and diarrhea. There were no grade 3 diarrhea, and there is only 1% of patients who had a grade 3 nausea. With brigatinib, there are a couple of other side effects we need to be aware. Brigatinib can cause elevation of CPK, which is creatine phosphokinase, which is a blood test. About 17% of the patients who were treated with brigatinib developed hypertension, and you might want to make sure you follow up the patient's blood pressure, and some patients require starting antihypertensive medication. There is also a very unusual side effect that I would like to concentrate more on, which is called early onset pulmonary events. About 12% of the patients who were treated in arm B, which was a 90 milligrams arm, which was then escalated to 180 milligrams, developed shortness of breath. Usually that shortness of breath happens at about day number 2. It is reversible with discontinuation of the drug. Majority of the patients have only mild shortness of breath. The grade 3 early onset pulmonary events only were reported in about 3% of the patients. So it is important to be aware of early onset pulmonary events, but it would not deter me from starting brigatinib because the event is reversible and easily manageable. We have gone a very long way in our patients with non-small cell lung cancer. I think it is very important to not forget to do molecular testing in our patients. Make sure that at the minimum, at least EGFR, ALK, ROS, and BRAF is included in your panel. I am a big proponent of next generation sequencing because it can discover other molecular abnormalities. We just had an excellent presentation of one of the RET inhibitors, which showed 77% response rate in patients with RET mutant non-small cell lung cancer, and that underscores our need to look for those mutations because I don't think we can afford of not offering our patients drugs that have such a high response rates.